Good morning, ladies and gentlemen. Great to see you all here at the Milken Global Conference. My name is Eric Schatzker with Bloomberg Television, and I am your moderator for Wellness and Prevention, Creating Healthier Lives and a Healthier Economy. Imagine if we could do all that in the space of 59 minutes and 23 seconds. Clearly, we all want to cut costs in healthcare, we all want better outcomes, and we want the nation to be healthier. How do we get there? That is what we're going to be discussing on this panel today. Let me introduce you briefly to our panelists. On my far right here is Steve Bird. He is the founder and CEO of Bird Health. He's the former chairman and CEO of Safeway, a role you may know him for, because Steve was a pioneer in incentive-based health improvement for his employees at Safeway. Beside me here is Lynn Goldman. She is the Michael and Lori Milken Dean of Public Health at the Milken Institute School of Public Health, George Washington University. That is a program that unites the studies of medicine, business, and education, perhaps uniquely in America. She is a doctor by training with a long career in public health and education at the state of California, at the EPA, at the Bloomberg School of Public Health, at Johns Hopkins, and now at George Washington U. This is Q Rhee. He is the health officer and vice president at IBM. He, too, is a doctor trained in internal medicine and pediatrics. Before joining IBM, he was the chief public health officer of the Health Resources and Services Administration and also director of innovation at the National Institutes of Health. And finally, Bernard Tyson is the chairman and CEO of Kaiser Permanente and has been with that company for more than 30 years. Impressive. He runs the largest managed care organization in the United States with more than 10 million members, 180,000 employees, and almost 19,000 physicians. As you can see, an incredibly distinguished and well-qualified panel for this conversation. A couple of small, yes indeed, a round of applause is in order. A couple of very standard housekeeping items. Could you please make sure that the ringers on your cell phone are turned to either off, preferably, or vibrate if you must. If you have to take a call, get yourself out of the tent as fast as possible so that it doesn't interrupt the flow and doesn't, more importantly, distract our panelists, or make it more difficult for others to hear what's going on. We are going to try and save some time. I'm hoping 15 minutes for questions at the end. I'm sure that all of you, given the fact that you're here, are interested in this topic and have some questions that you want to pose to any one of our panelists or all of them that I may not ask. So let's get going, shall we?
Sounds good.
Most people, I think it's fair to say, think of health as a reactive system. I get sick, I go see the doctor. Somebody, maybe me, but probably not, will end up paying for it. Here's what I want to start off with, because this really cuts to the core of the question that we've been asked to answer. How much of a difference can a proactive approach to health, that is, let's call it, for lack of a better term, wellness and prevention, how much of a difference can this proactive approach really make? And I'm going to ask Lynn to start off.
Well, I think it could make a tremendous approach. I mean, one thing that we know is that 50% of the things that kill us are actually preventable using methods
50.
50. And look at the rising costs of healthcare costs
You have a slide
our
that
national
illustrates
healthcare expenditures. Yeah, I do, although I see it and you don't. Slide number 1. In the United States today, we see really an uncontrolled rise in expenditures, and yet we don't see a commensurate rise in value. And partly it's because the things we already know that we need to do, whether it is controlling tobacco, whether it is controlling hypertension, increasing physical activity, or paying more attention to our diet, that we're not doing those things. And so there is a tremendous potential for bringing these costs down, but also for making our lives healthier, for extending our lifespan, for decreasing disability that we are not tapping because we aren't applying the things that we already know.
So, and Lynn is exactly right. One of the things I want to frame is when we think about prevention, one way I frame it as a physician is I think about the training that I took. I trained nearby here at Cedars-Sinai. I focused a lot of my attention on what I would consider tertiary prevention, so the treatment of disease. And if you start looking further upstream, you look at things like secondary prevention, detection of disease early, or primary prevention, which is the prevention of disease. Those behaviors that Lynn was referencing, that can prevent those chronic diseases. When we look at our healthcare system and that spend, most of our spend, 90% plus of it, is in the tertiary prevention, the treatment of disease. And something like primary care, as a primary care physician, the early detection of disease is a big part of what my role is as a primary care physician. So that's only about 5% of all total healthcare spend, while the actual prevention of disease is closer to like 3 to 5% of all healthcare spend. So ultimately, we need to start looking further upstream and being more proactive and less reactive.
And I would build on that as a non-physician.
But a guy that knows a lot of doctors.
And runs a lot of doctors, like 19.
But, you know, the way I would describe it is if you call this end birth and this end death, the entire healthcare system is financed right over here. So you have all this white space here. And the fact of the matter is, in this white space that I call the healthy life years, people behave in ways that can cause major illnesses and other things to happen to their bodies. So to the earlier point, if we can help people to focus on being active, eating healthy, managing alcohol and tobacco, you can greatly influence diabetes, other diseases that is very expensive in the treatment of care. And that's what the behavior and the prevention is all about, is changing some of the patterns that's going on in our systems today.
You know, I got involved in healthcare in 2005 when I was the CEO of Safeway. We had a healthcare bill that was $1 billion a year, and it was growing at the rate of 10% per year. We had 185,000 employees. We covered about 350,000 people in our healthcare plan. And one of the things I picked up on early, Lynn, was that if you look at all the costs of healthcare, about 70% of it is driven by behaviors. And as a business guy, I thought this is the best news I've heard in decades, because you can actually influence behaviors. I think the opportunity for everybody in this room is to get involved in wellness and integrate it into your own healthcare plan design. If you're a self-insured employer, you have a greater opportunity to do that. In about a 5 or 8 year period, we actually lowered the biological age of our workforce 4 years. And if I could have slide 15, it's a powerful demonstration of what you can do. That happens to be 16, I think. Oh, give me 16. They renumber these for you. So we were the first to introduce biometric screening, the first to do outcome-based rewards, the first to do reference pricing, the first to introduce transparency. So all of that played a role in creating these results. But for the people that failed the blood pressure standard, 2 years later, 73% of those people passed that standard. For the people that failed elevated glucose using the HbA1c level, and there's no magic pill to accomplish this, 2 years later, 45% of them achieved that standard. In cholesterol, 43% that had failed achieved standard. Tobacco, that number is probably a little vague here because we test for it, but you can beat that if you can stop smoking your 2 packs a day for 8 days. You can beat that test. And BMI, one I'm particularly proud of. When I started this program at Safeway in 2005, 28% of our workforce was obese. That's lower than the national standard because people are on their feet all day working. 2 years later, we had reduced that by 21%. Today, 21% of the workforce at Safeway is no longer obese. Those that had gotten below a 30 BMI, 70% of them remain below that BMI. And it basically cut our healthcare costs in half over an 8 year period. And in the last 2 years, 2013 and 14, because of the improvement in the health of the workforce, Safeway has experienced a compound decline in healthcare costs of 9% each of those years.
So I love the data, and I want to extend the question to both Lynn and Bernard, and Q, if you want to jump in by all means. To what degree can these results be extrapolated? At an organization like Kaiser Permanente, if we can go back to slide 1 for just a second, Lynn's slide, we see that, if my rough math is correct, from 2015 to 2023, national healthcare, total healthcare spending in America is going to rise by about 65%. Steve, you're talking about, in some cases, cutting expenditure by 50%.
Correct.
to what degree can that be extrapolated at an organization like Kaiser Permanente?
Well, to a great degree, and I think Steve has demonstrated what can happen with good data, a motivated workforce, and strong leadership, and putting the right incentives in place. And we can demonstrate this. We collect data on all 10 million of our members, and we aggregate data. We share it with employers, some of our major customers. We offer ideas and programs that could be implemented that starts to get at the issues that Steve is describing.
Do you see results already?
Oh, absolutely. Our cost trend over the last couple of years has been less than 3%. It's been around 2.5%, 1%. We give that back to our customers in the form of more affordable pricing. The ability to work with people, to partner with people, to work on patterns of changing behavior is very possible. Now, at the same time, it's not a one-size-fits-all. There are problems in many communities around the country where they may not have the grocery stores, or they may not have the safe environments, or they have environmental issues that would prevent or slow down the progress. But we've also been able to demonstrate we have 65 farmer markets around the country because we discovered in some of our neighborhoods they didn't have access to healthy foods. And guess what? People in the inner cities, et cetera, they like broccoli, they like all the things that we talk about. It just wasn't available inside of those communities. And so we're now starting to see those patterns in those communities as well.
Do you see a similar response among IBM? The reason I ask this question is because we've all known since we were kids that eating better is good for you, smoking less is good for you, drinking less is good for you, and leading an active life is good for you. But it only begins to really sink in when we can begin to quantify the impact of these things.
So one way I like to frame it is having the right information at the right time to make the right decision. And ultimately, you want to make the healthiest choice, the easiest choice, or sometimes the default choice. So when I think about IBM and our current healthcare spend globally, we spend over $2.5 billion a year, about $6 million a day on healthcare. And that's an extraordinary amount of spend that we have. And as I suggested earlier, if you look at the spectrum of preventing disease to treating disease, the significant majority of that spend is in treating disease. And part of the challenge is that's where a lot of our focus, that's where a lot of the evidence, that's where a lot of the peer-reviewed literature has been focused in that area. And ultimately, we need to build more real-world evidence together. Because, frankly, I know I should be physically active. I know I should eat healthy. This has helped me.
That tells you?
Be self-aware.
This tells me?
Yeah, that tells you. How many people? Yeah, you've got one. We're all becoming more self-aware with this instrumentation of data and this opportunity to connect that data and get more intelligence.
I'd like to go back to something Bernard said about leadership. I think it's all about leadership. And it's particularly important if the CEO comes to the conclusion that it's in their best interest to protect the human capital that they work so hard to attract, develop, and retain, that they get interested. We built a culture at Safeway of both health and fitness. And the reason I got interested in the fitness component is I'm 65. And I learned from friends that were a bit older than me that if you're not fit when you're 65, you're going to be in trouble someday because mobility determines health in later stages of life. And so it's very important to be fit. And I look at this whole thing as an ecosystem where you can't say your organization is about health and fitness and then subsidize every meal in the cafeteria that includes onion rings and fries and all of those things. You can't bring things to meetings that are unhealthy for people. And at Safeway, I think people think it was all about biometric screening and outcome-based rewards. It's so much bigger than that. It is about building a culture of health and fitness. And if you're a large self-insured employer, anybody with 5,000 or more employees, everybody in this room can make this happen in their company.
So if we could look at number 10,
slide number 10.
Slide number 10. One thing that we know
is
that
10 or 2?
10.
10, pardon.
We actually invest very little of our healthcare dollar on prevention, 4% at most, and this has been stubbornly at that level year after year after year. And we're talking about investments made by all of us, not just by the government, but by all of us. And yet we know that prevention is far more effective. If you go to the next slide, 11, the return on investment from even $10 more per year that would be spent on each one of us for prevention would yield $16 billion in 5 years of returns. The ROI on prevention is unbelievably favorable, but perversely, our healthcare system doesn't reward that. Our healthcare system doesn't have a single budget where all the health is. If you were running a company this way, you would fail. And indeed, our healthcare system is failing because of the fact that it is run this way. And I think it's why all of us need to work in partnership to find alternative ways to get things done. Because frankly, we've been trying for a long time to reform this in the way the government does it, but that happens very slowly. But yet, as Mr. Bird points out, what they've done at Kaiser, what they're doing at IBM, these are ways of moving things forward. I want to give another example of that in slide number 26, which we had a mayor from Oklahoma City that was going to talk about, which is that we can also change the way we design the environment in which people live to make the environment healthier. And in fact, the nation's capital, Washington, D.C., has put bike lanes and walking areas everywhere, public transportation. And car ownership is actually going down in the city because a lot of millennials prefer to walk, to bike, to use other means to get places. We even see companies moving their headquarters so that they're closer to these bicycling routes and metro routes because that's the way their employees want to get back and forth to work now. And so in some of these people, we don't need to push them. We need to provide the means that they can do what they want to do already. They want to walk, they want to bicycle, but in so many places, so many communities, it's just not possible for them to do that.
Can I connect the dots on something you said earlier? Because I think there's another dynamic that's happening here as well. If you take the average American worker now, the Kaiser Foundation tracks this statistic I'm going to share with you, and it goes back to the late 90s. So inflation has increased 1999 or 90 to 2014 was the last year. Something like 46%. The average worker's income has gone up about 56%. The average insurance premium over this time period has gone up about 190%. The average shift of the cost on the backs of the workers has gone up 212%. So what does that mean? It means for many, many, many years, the average worker has not seen a real wage increase when you look at the economics of what goes on and how the employee is making sense out of their lives. And right now, the cost of health care on the backs of the American worker is almost 20-something%, if not slightly over that, depending on where they are on the economic scale. So you also have the American people very upset with what's going on with the cost of care, and they're asking different questions. And so if I come along or Steve comes along and we show and we demonstrate, one, the interest in our workforce, two, new ideas about how to address it, and thirdly, to walk our talk. I mean, one of the most difficult policies that I implemented at Kaiser Permanente was the food policy. And it was amazing to watch people. For a while, I was scared to go to my car. Bacon was a big deal. And when I said, no, we're not going to do that, or cookies. Some people go to conferences at Kaiser Permanente, they'll rate the conference as a 10. They'll rate the food as a 1 because we got rid of the cookie. Yeah. But now people are knowing that we're serious about it, and it's a step towards saying we're going to walk our talk here and help you and help ourselves to become more healthy.
So one thing, this idea of a culture of health, that companies need a culture of health, I think is something that people can embrace in thinking about programs and policies that promote that, such as a food policy internally, or policies in terms of how you do screenings or how you do certain types of incentives, whether it's outcomes-based or process-based. So there's a lot of opportunity there. I will say, though, when it comes, and I was highlighting it earlier, when it comes to the evidence in this area of primary prevention, which is getting more and more robust, there needs to be a recognition that we need to develop more of that evidence.
Right.
And it's going to take all of us working together to do that, because and that's where I think this opportunity around data, where all of this data, the average person will create about 300 million books worth of data in their lifetime. If you look at all the wearables, all the things I got here on me, I got a Lumo lift that checks my posture, that reminds me when I'm slouching, which is just kind of buzzed. I've got this, what do I got here? I've got, there's a EKG you can now have on your phone, a live core. You can, and I take this with me, and my father has a heart condition, and I can check it. And I gave him one of these that you can actually, and I get those results from him. So and then of course, things like sleep can be tracked. I mean, we have to recognize that this age of big data, the ability to get this data, and we're very proud of it. If you look at slide 38, one of the things we just recently announced is the Watson Health business division, and then the Watson Health Cloud, which is now connecting data from different structured and unstructured sources, bringing it all up, including wearable data, that exogenous data, the data you were talking about, the behaviors that are perhaps 70% of health outcomes. And then you look at how you can derive insights and solutions for the different groups that are paying for the healthcare system. I get very frustrated. If you talk about our healthcare spend, let's be upfront. Healthcare spend continues to rise. And I know the Institute of Medicine says 30% of healthcare spend is wasteful. So if I look at that $2.5 billion, that means there's $700 million that we can save somehow by improving and addressing the healthcare system. And I also think focusing on more of a culture of health and primary prevention.
I want you to get into a little bit more detail. You offered one example, Lynn, of the bike lanes in Washington, and you offered the example of forcing change on a company cafeteria. What else is working?
So if I can mention one thing, and those of you in the audience, I'm sure you all have regular medical care, but how many of you actually can recall the last time you had a tetanus, diphtheria booster shot? Do you actually know when it was? So most of you don't remember exactly when that was. And one thing that we do know that works is with immunizations for adults, having registries, or even better, if we had electronic health records that actually talk to each other. And I know IBM has been working in that space and many others, but we do not have a system in the United States that connects the dots with our health records. And so when we have something like, for example, this measles epidemic that has been happening in the US, why? Because of the fact that not only a lot of the children are not immunized properly, but also some adults never were or never received the boosters that they needed. And unfortunately, most adults have no idea if they had a measles shot when we do surveys. And we don't have the records. When you go into your doctor's office, you know, maybe you had that done at your pharmacy, maybe you had that done at another doctor's office. You can't really remember exactly when it was, and most of you can't remember exactly which one you got. But we know that works. And that's something that is very amenable to technological approaches. Same with blood pressure. You know, tracking blood pressure. Why do we fail to get people with high blood pressure into treatment and to keep them in treatment when we know that that prevents heart attacks and strokes and keep people alive? But because most people are not in healthcare systems that do a very good job of tracking those things. Now the workplace can do that. I know that Steve was doing that at Safeway. I think that's commendable. That's another way to try to address that. But there have to be technological approaches. We don't have any excuse in this age of letting these kinds of things fall through the cracks.
But we do that, and it goes back to your comment as well. I think that it's a great demonstration of how far behind we are in the healthcare industry. The fact that we, in most cases, haven't even gotten to electronic health records, even though we're moving in that direction.
Slowly.
And it's slowly, right? So all 10+ million members of Kaiser Permanente are on the electronic health record. And you start to track trends, and you start to aggregate, and you look at patterns, and then you start managing to individuals and to populations. Your intelligence goes up. There's no excuse not to collect some of the information that allows you to have a holistic approach to how you think about the individual. I have many people ask me, why do you wear this? Does it really help? And I say, yes. And they say, how does it help? I said, it's making me think about health. It's making me think differently. Is it perfect? No, but guess what? I wonder how many steps I take a day, and I keep track of that. I feed that into my physician records. I do things that, in which I'm much more proactive in my health and in my own well-being, and I have a health system that is there to partner with me to help make that happen.
So,
Yeah, you asked the question, how do you really sort of activate this in an organization? You know, it's really important. I go back to this ecosystem. You know, we can wear all these devices, and I can tell you that if you don't make changes in your healthcare plan design, the only people that will wear these will be your fit people, right? So you have to make fundamental changes in plan design. There's nothing that says you can't say you're 53 years old, you've never had a colonoscopy, you've worked here for 35 years, your premium's going up next year. That's perfectly permissible under the law, and yet very few people do it. When we introduced outcome-based screening, or excuse me, biometric screening, again, I said we were among the first. 10 years later, about 30% of companies today do it. You won't find 5 companies in the United States that link it to outcome-based rewards, and not in the true sense. And there are some reasons for that, and we may go into that a little bit later. But I will give you an analogy with the automobile insurance industry. Ever since we were 16 years of age, we've all understood that driving record determines premium. Why shouldn't healthy behavior determine premium? It's permitted under the law. And so if people are going to smoke, if people are not going to take care of themselves, we recognize there are some genetic predispositions, and the law and the way we approach biometric screening and outcome-based reward, it all allows for that. The single thing that we did in the company that was the most pervasive positive effect was creating social groups, small groups of people, 8 or 10 work together. They had their own personal goals, they shared those goals, and they monitored them weekly. So as the CEO, I got 8 of my executives in this first social group. We all set our goals. As the CEO, I couldn't allow any of my subordinates to see me fail on my goal. And guess what? They felt the same way. What we did at Safeway, the plan was all voluntary. 85% of the people volunteered to be measured every year. And if they made progress on, let's say, obesity, we gave them a check at the end of the year for achieving a 10% reduction. This was not about raising the premiums, this was about improving the health. And I think the numbers speak for themselves.
Is that the way to fix the broken system, through better incentives?
I think it's one way. I think that, you know, when Dr. Reed talked about culture of health, this is a part of that you create incentives, whether, you know, it's in the workplace or in schools, like our university, where we're trying to make some of these changes. I also think that there are other things that we need to do. And, you know, changing the food that's available at meetings, changing the food that's available. Frankly, we did this at GW in the university meal plan for the students, making sure that there's healthy food that's actually available. And that's not true in a lot of the universities across the country. I don't know if the proud parents really understand that, you know, the food that the kids get every day in the cafeteria isn't the same food that they serve on Visitors' Day. I hate to say this, but this is something that needs to be addressed. And so I think that these things need to occur on many levels, and we need to start creating many partnerships, you know, among, you know, organizations like companies and healthcare plans with their communities. I know that Kaiser's done this. You've done a lot of work with your communities. That might be worth talking about a little bit, actually, because this is a problem that requires solutions on many different levels.
I agree with Lynn.
Excuse me for just 1 second, Steve. I need to be the bad cop for just 1 second. There's somebody having a conversation in the room. Please take it outside. Thank you.
You know, I don't want anybody to walk away with the impression that I think there's a silver bullet out there called outcome-based rewards. You have to do about 50 things, and that's why I referred to it as an ecosystem. I think that you know, measuring people biometrically is necessary but not sufficient. I'd just like to show one slide to make this point. Slide 15, because there are other groups around the country. There's a business group associated with the American Heart Association that is doing biometric screening. And they associate that with activities. So they reward you if you're wearing a Fitbit. They reward you if you if you stand up and sit down 50 times a day, whatever the activity is. The difference between outcome-based incentives and activity-based incentives, on cholesterol, we have 5 times the result of any other national study in the United States. On blood pressure, 7 times better. You know, if your insurance company said, you know, if you have a lot of parking tickets, or excuse me, speeding tickets, we're not going to raise your premium as long as you promise not to do it anymore. No, they're gonna charge you more until you prove that you have a better driving record.
So, you know, it's a great question, and it's a complex question because
There's no silver bullet, right?
there's no silver bullet. But what we're working on in our total health system is actually connecting health to everyday living. Health is not this thing over here and then life is over there. We're saying, look, it's all combined, right? So everybody here and everybody in this country, we're all pursuing the same thing: life, liberty, and the pursuit of happiness. And I would argue it takes good health to get there. We wake up every day with all kinds of stresses. One of the most pressing issues we have in the healthcare system and the health of the American people is mental health, stress, right? Stress causes certain behaviors, and those behaviors can affect the human body. That's a complex issue within itself. And I have been arguing now, and we're working on this in Kaiser Permanente, that I call it, we got to reattach the head to the rest of the body, right? Because the way we treat mental health is it's over there in the corner, we tell you go over there. We're saying, no, we need a holistic approach of how we deal with mental health in the 21st century, because that's a part of the everyday living. And so the incentive program clearly is a very effective tool and incentive, and I've seen people react to that and respond to that. And there are other things that creates different kinds of incentives, the things that we're doing in communities in which we engage and activate communities around the country to take a holistic approach to the health of their communities, impacts the health of the individuals, the school system, the jail systems, the police systems, you name it. It's creating a different kind of environment for people to exist in.
So one of the things, if we go to that, exactly what Bernard says, if you could go to slide 37, one of the things I want to highlight and transition, this concept of pay for performance. If you think about the accountable care organizations, I look at the data as a large self-insured employer. I can see the data in primary prevention. I can see vaccination rates. I can see flu shot rates. I can see kids' vaccination rates. I can see medication adherence rates in the treatment of disease. Under tertiary prevention, I can see our mammogram rates, our pap smear, colonoscopy rates, and a lot of this data is accessible in a de-identified, aggregated way that helps me be proactive and also recognize the effectiveness of the programs that I sponsor or support or try to influence. I think the future of pay for performance in terms of perhaps from an employee or a patient perspective is probably going to evolve towards a personalization. I believe in, as a physician, I didn't like telling people, you know, you have to stop smoking, you have to lose weight. I mean, in those 7 minutes where you have 7 minutes with a patient, I mean, how much time do you have to go through? And frankly, doctors aren't that good at influencing those behaviors. So the idea of somehow personalizing, we call it self-management goals, I think is a better way to approach it so that people can identify, this is what I want to pick. I want to pick losing weight. And someone else might say, I'm not ready to stop smoking. I'm not at the right stage of change to do that. So let's try to figure out something you're willing to do. So one of the things I want to emphasize is that health is so much more than health care. And that's one of the recognitions that I had as a physician working in community health centers in the District of Columbia and taking care of people in those 7 minutes with that limited amount of time and seeing how challenging it was to sometimes address those behaviors, how challenging it was to see the broader picture. And it includes things like genomics. It includes things like environment. If you look at a map in the Metro map, the Robert Wood Johnson Foundation does a great job of it. You can see life expectancy varies based on where you live. Why is that? Because a lot of the factors we're just talking about, where you live does play a role in your health. Education, employment, behaviors and habits, social influences. One of the best questions you can ask somebody about their health is if you have an emergency, do you have someone to talk to? talking about what Bernard was saying in terms of mental health and social influences. So at IBM, we have 5 dimensions of health. We think about it much more holistically: physical, mental, social, financial, and purpose. And the reality is we have to think much more holistically about health than just the physical.
But when you, so to build on this, and for me it is really the breaking point of healthcare versus health. I mean, in reality, at the mega trend level, for our entire healthcare system that I was talking about over here, that's finance, for the sake of this, these are gross numbers. About 20% of that population occupies about 70 to 80% of the dollars, all right? And then if you take that 80%, almost 90% of that is spent in the last 12 to 18 months of a person's life. I mean, in the aggregate number, that's where all the dollars are going. And the question is...
In life extension.
Yeah, and so the question is, how do we start to peel away at the economics of the healthcare system that many would argue is suboptimal?
So how?
And in some, well, we start to get at these kinds of issues. We redesign and transform the payment system, for example. So the American healthcare system is pretty much still on a fee-for-service system. You get paid for volume. We start to question that. We force incentives that and force us as an industry to start to build the electronic health records and ways of tracking through interoperability. We create new incentives around the insurance and the coverage of lives, and how do we start to influence the change in behaviors? And then we shift that money more upstream for the better use around prevention and other kinds of things that we can do. I mean, your statistic earlier about the inefficiencies of the healthcare system, that alone is something we all should be working at in this country.
Well, and if I can add to that, which I completely agree, but and also we need to shift the focus from the end of life to the beginning of life.
Yeah.
Because we know that so much of chronic disease has to do with very, very early childhood exposures, even in utero experience. If a mother is smoking during pregnancy, the impact on health is for over a lifetime. We know that. And so to focus more attention on protection of pregnant women, the children, addressing children's health, making sure that they are immunized, making sure that they receive a healthy diet at school as well as at home, physical activity at school. My own daughter didn't have a requirement for PE, physical education, all through school. And I think that that has a substantial impact on health, that these children are driven to study, they're driven to spend a lot of time on intellectual activities. That's all very good. They're going to spend a lot of time looking at their screens. They need to be active. They need to be provided with a decent diet. And by the way, they need to learn early how to cope with stress.
Yeah.
Our children are under a lot of stress. And that starts early in life as well as learning how to cope with that. But all of our attention is on the end of life.
Some of this, though, requires policy-based solutions, right? You know, some of the success that you've had, Steve, and what you're doing at IBM, you've been able to achieve because it's a self-contained environment, right? It's a corporation. You can, to a certain degree, either tell your employees what to do or encourage them, incentivize them to behave in a certain way. To the degree that policy changes are required at the municipal, at the state, or at the federal level, how?
Well, again, you know, what I showed you before up there on the screen, $10 more a year per person in this country would make a substantial impact on this. We're not talking about a lot of money. It's just that the resources that are available for prevention are a tiny fraction, you know, only a few percentage points of the overall health budget. We just don't make wise decisions about that. But I also think that this is true with companies as well. I think that there are things that can be done with, for example, family and medical leave, ways to support people in their role as parents so that they can do a better job with nutrition and healthcare needs for their children. More engagement. We all need to be more engaged with what's going on in schools, and making sure that schools have better foods available, and physical activity. And many companies are doing this. They're investing in programs in schools, in their communities, to try to support that, just recognizing that in the long run, that makes a tremendous difference for all of us, for the bottom line, for all of us.
The public policy issue is a very interesting issue.
You engage with government leaders at all levels.
Yeah, it's not, you know, it's difficult, but I would say that at the very least, we need to figure out how to have the public debates to decide, are there other things that we should do? I mean, the other, so to frame this, you know, just right quick, I went to the birth and death, and when people were only living to like 45 or 50, healthcare and health took care of itself, right? Because people died. And then there were actually two major things that happened, you know, quite frankly, that we take a lot of credit for in the healthcare industry, but actually it happened generally because we learned how to handle waste, you know, sanitation, and how to preserve and do foods differently. The outcome of that is that there are really two ingredients inside of our diets that causes a lot of the problem, and that's salt and sugar, right? Major problems from preserving foods through salt, and obviously we're all now attuned to sugar, and the health effects of that is being proven over and over again when it's not used appropriately. We have figured out in this country how to tax cigarettes. And we are very aggressive in taxing cigarettes, and people pay more for cigarettes because we have decided in this country that smoking is bad for you, and if you decide to smoke, you will pay more for those cigarettes because you cost more to the society, et cetera, et cetera. I'm not saying that the right answer is taxing more for this or taxing more for that, but I think as we gather more data and bring more evidence forward, we need to start posing those kinds of questions for us to grapple with, like we do every other issue that we deal with in this country.
So, you know, we've talked around it, but I don't think anybody's used the phrase personal accountability. I mean, personal accountability is really the foundational piece that you need to put in place. So, you know, tobacco taxes, it's hard to argue with tobacco taxes, but I'm not a big fan of taxing everything with sugar or too much salt or any of those things. But if you are personally accountable, you know, for your BMI, for your blood pressure, you might be predisposed to high blood pressure, but it doesn't mean you can't take your medication on time. You know?
But to whom are you accountable?
You can be accountable. You're accountable to yourself, and it should have an implication on your healthcare spend. Imagine if all of our companies decided to pay for automobile insurance. Trust me, they would build a model exactly like we have today. And so I think that model is a useful thing for everybody to look at because it allows you to think creatively. I mean, people thought what we did at Safeway was very creative. I just sat down one day and thought about automobile insurance and then kind of mimic that.
So I want to, I mean, I like, obviously, accountability. I like the idea of shared accountability. When we looked at the stakeholders that are part of this healthcare system or this health system, and look at how much we're paying for it, especially in the US, $1 in $5 for a system that frankly often doesn't work, then we need to be thinking about this concept of shared accountability. So one of the things, so I actually think of 3 priority areas in terms of, you have to realize companies are policymakers in their own way. They influence policy, but they can set their own local policies. So empowering individuals is a very fundamental tenet at IBM. So we've given our employees Fitbits. We've given them in Japan, we've given them in the US, and it's fascinating to get that aggregated data now. What do you think is the average number of steps an IBMer takes?
I'm gonna say 10,000.
8,800 approximately in the first year. So it's just, you're making people self-aware, empowering them to be self-aware, but you're also starting to look at this data and getting more deeper insights about things. So let me just do 2 more areas. So the other idea of transforming healthcare. So what is measured is what gets done. And one of the challenges we have in healthcare is we focus so much on tertiary care. Those are the measures that are focused. Frankly, I think we have to move to a place where we expect, if we're paying healthcare institutions to address healthcare-acquired infections or errors or getting people out of the hospital, no readmissions, we have to start looking upstream about measures like smoking prevalence. Do I expect my healthcare institution to help reduce my smoking rate? Yes. Do I help them, expect them to reduce the BMI of my population and their family members? Maybe yes. So looking at the measures that matter, and we think about measures of quality, especially in primary prevention, secondary prevention, cost, engagement, which is another major issue. People don't like to engage with their doctor. How often would I see a patient, they're like, oh, doctor, I'm sorry, I didn't want to see you, but now that I've got this really worrisome lump, or I've got this worrisome blood in my stool, now I'm here, or I'm going blind. So challenge, the issue of engagement is important, and experience is important. And frankly, the healthcare industry, Kaiser has one of the best engagement scores or experience scores, net promoter scores in the industry. But why can't we expect experience scores or satisfaction to be high like it is at places like Kaiser or Costco or Apple? There's a broad range of industries that have done extraordinarily well in customer satisfaction. Yeah. And then the last item is democratizing health and wellness. That's where I think we're moving towards. The reality is, if you look at what Bernard was referencing in terms of costs, that cost is getting more widely distributed. It's not just the employer paying anymore, it's often the employee. And so what's going to happen in this age of big data is that people will have access to data, and health and wellness will become more democratized. And I think that's going to be very exciting.
Before we open it up to questions, Lynn, you wanted to make a point.
Well, because I didn't want to let the sugar industry off the hook here, not just in terms of whether there might someday be a tax, but the fact that we already do have a tax policy that relates to sugar, and that is that we subsidize the production of sugar. Our taxpayer dollars pay for subsidies for corn, for actual sugar production. Tobacco is on the list. And if you look at which are the crops that we already subsidize, you'd have to flip that list upside down to say which are the healthy things that we want to put in our diet. We do not subsidize the production of fruits and vegetables and other healthier foods that we actually feel that people should be eating. And so we have driven down the price of sugar so that it's very cheap and easy to just put it into everything. So I think that we do have some policy issues that we need to look at around those.
We have a few minutes for questions. There are a couple of wireless mics in the room, people at the back. So, all right, why don't we start right back there, because the mic's there.
Good morning. My name is LaDon Mantegi. I'm with Georgetown University's Business School. There's a lot of data that's being collected, obviously, with these wearables that you've talked about. And I heard most of the conversation being about the wearables and the data being used to inform the employers. And that's terrific in terms of being able to make decisions. However, what's being done to actually empower the consumers and the employees to make better decisions about their own health using the data, to be able to actually go to a doctor and have a more informed conversation and controlled conversation rather than just a quick visit where the doctor controls the visit?
So I'll take that first. One of the things I've recognized at IBM is that every day in the US, over 10,000 decisions are made in healthcare every day. About 4,500 medication refills are done, about 4,000 doctor's visits, about 100 ER visits, about 25 hospitalizations. There's an extraordinary amount of data there that we get in an aggregated way, de-identified, and you can use that data to personalize interventions, as you suggested. So one of the partnerships we have is with WellTalk, that's leveraging Watson, that's looking at the data that a self-insured employer gets, personalizing that data to an employee with their consent, and then getting insights so that if I were a diabetic, I'm here, then it would recommend restaurants.
That's still within the framework of IBM, and for the purposes of our conversation, only IBM, right?
No, it's broader than that. I mean, there are other companies like WellTalk could be used by anybody, actually. So I think this idea of personalization and leveraging population health data from different sources is something that a lot of companies and a lot of industries are doing. Like Kaiser uses the physical activity as a vital sign, which is a great.
Well, I think it's a great question. There are two parts for me. The first one is within the Kaiser Permanente system, we're not just relying on the physician. So we have knowledge workers in pharmacy and nurses, et cetera. But the second part is we're creating different access points. And so the traditional American healthcare system is set up where you come to me, the physician. And we're showing that you could distribute care out. Last year, we had 27 million e-visits by the technology. This year, it's going to go up to about 30-something million. We had something like 38 million phone visits. We had about 65 million face-to-face encounters. And so we're opening up access in a very different way because people are asking questions about their health and getting more data and therefore becoming much more engaged in their health process, which is very helpful.
So there also is a proliferation of apps that are actually directly for the consumer to help them. One of my faculty has developed one called Text for Baby that a woman can use when she's pregnant, and it reminds you of the things that you should be doing every day, prenatal care visits, but also it's been piloted in Africa where people can use it to actually get in contact with a healthcare provider, say they live in a remote location that doesn't have a health provider, and be able to be in communication if there seem to be any problems, you know, to get advice, find out when they need to come in and get help. And I think increasingly we're going to see people using them. There is a challenge about which of these actually work well, which of them are good. We have another one that supports people in quitting smoking, which has been shown to work a lot better than just programs where you're getting advice from your doctor, because it turns out doctors aren't great at doing that.
I want to move to the next question, but Steve, do you have a word on this?
You know, I'm gonna just save it because I think we could do 2 hours on your question. I mean, Bernard, you mentioned it earlier. The subject is so broad, so I'll save myself for the next question.
All right, I'm not sure who to go to. I'll leave it to the discretion of the mic handler.
Mic holder.
Thank you. Hi, my name is Darrell Dipty. I'm a U.S. Naval officer. I believe that the average American has a very warped definition of what it means to be healthy. Right? We try to hold people accountable, but the average person thinks that if they read the nutrition facts, eating 300 grams of carbs per day is okay, when we know that sugar is just as addictive as cocaine, and also that sitting at a desk for 8 hours a day is okay, very sedentary lifestyle. What can we do to better empower our citizens to embrace a healthier definition of health?
You know, I'll start with that one. You know, it's about, I sound like a broken record, but if you're in an organization, and we all are in some organization or another, you create a culture of health and fitness, and you define what that is, and you overload the organization with bits and pieces of information. You know, what we always try to do is we try to integrate their normal everyday activity into things that result in health and fitness. So at Safeway, we would have a 35-minute walking meeting. You know, if you don't need to sit in front of a screen, you can go do that walking. And so we had hundreds of employees that walked every day. All of these social groups that formed, 1,000 or more of them formed every day around certain goals and objectives. We brought in speakers to talk about breast cancer. We brought in speakers to talk about heart disease. And we educated them. We created websites that they could access information on. So if someone wanted to lose weight, they could go to a source on the web, and we would give them 1,000 ways to burn a half a calorie a week. And I always throw in resistance training. I mean, most people don't do resistance training. If you lose 30 pounds and you don't include resistance training, you're going to lose about 8 pounds of muscle. And if you're in your 50s, that's a very bad thing to do because it's harder to put that muscle back on.
Right.
If you're an executive and you talk on the phone 6 hours a week, should you choose to stand and pace the floor while talking on the phone 6 hours a week, you will burn a half a pound a week. If you choose to pick the stairs, let's say you go to a soccer game, don't sit in that lawn chair, walk up and down the field. And if you do that, you will burn calories. If you play golf, don't get in the golf cart, throw it over your shoulder, half a pound golfing on Saturday, particularly the way I play. Maybe a pound, You walk a lot more.
I mean, the other half of the question, that food label, I think most people look at that label and they see 25 grams and they don't really know what that means. And I wish it were clearer if it were, 5 teaspoons stacked up or something that would illustrate to a person how much sugar that really is. I think it would be clearer.
I think we have to make it fun and engaging. I think that's one of the areas we can't over medicalize or make it seem somewhat paternalistic or maternalistic. We've got to make it fun and engaging. So one thing I reflect on is we've got a team. Our team has 400 folks have Fitbits, and then we challenged someone else's team to a Fitbit challenge. They have about 400 folks. And then basically me and the other leader, we agreed that whoever's team loses would basically have to shave their hair bald. And so, and my hair grows back pretty fast, so I was feeling pretty good about that. But how do we make things fun and engaging and recognize that the social networks are such an important impact? It's not about kind of always individuals, it's about the connection. So there's good research that shows people lose weight and gain weight and stop smoking and start smoking in their social networks. So as a physician, I think if I can influence one person, then that means I can influence a network of people.
Yeah, I'm in total agreement. You know, it's a journey, and a lot of people don't know what they are eating and consuming. It's very hard to define. You know, I used to take a canned drink and show kids how many teaspoons of sugar is in there. Then when you start to show that you get the 8 to 9 to 10 teaspoons, they go, really? And it just is an eye-opener. And you just don't naturally think about that when you're drinking that can.
Let me add 30 seconds. When I did my quarterly earnings reports, I would go into a town hall meeting to speak to about 500 employees. It was broadcast to 185,000 employees. I did the quarterly report on the health and fitness of the organization. Didn't do that to the public shareholders, but I released the earnings. I talked about earnings, and I talked about the improvement in health and fitness of the organization. And it has a powerful effect. You have to, Bernard said earlier, you have to walk the talk. You can't just say this is something we want to do.
All right, we have time for, if you don't mind, Lynn, one last question over here, I think. And then we're going to have to wrap it up, I'm afraid. Sorry for those of you who have questions to ask and won't get them answered.
I think there was a Wall Street Journal article a year or so ago about the healthiest zip code and the most unhealthy zip code in the United States are within a few miles of here. And I think a lot of what we're talking about today, it's amazing how much incredible low-lying fruit there would be in our socioeconomic arena. And it's unbelievable that more companies haven't done what you've done. But I would think that the 80% you're talking about, the 20% of the people that are using 80% of the healthcare are in the inner cities that do not have a company to answer to, do not have a healthcare system to answer to. I think well over 50% of our 911 calls are for, have our firemen respond to people for healthcare issues because they don't have insurance. So I think that's the bulk of what we're ultimately talking about in these costs. How do you reach these inner city people and stop them from eating, McDonald's for 3 meals a day, and the kids, that are born to smoking mothers, or, that's especially in this area. There's 24 million people in Southern California, and the bulk of them are not us.
Well, but you get into the bigger societal issues, quite frankly, and what you have is a country divided between the haves and the have-nots. And I go into all the communities, and by the way, there are people in the inner city. They want to eat the good food. They want to live the healthy life. They want their kids to grow up and be successful. But they look out and they don't see that future. And the question is a bigger societal question. And I think it's an excellent point that you're raising about how do we come to terms with the complexities of where the dollars are being spent in this country. I can't tell you how many moms I've talked to that would say, look, I would love to offer this, but guess what? I only can afford the $1 hamburger for my children. And so are you telling me don't put no food on the table or do the best that I can do? You have kids growing up in some of the areas in which they can't go outside because of the crime and the fear of crime. And so they're not exercising, and it goes on from there. On the other side, you have I'm being dramatic, but you have the other side where we lock ourselves up behind gates and behind all these things, and then we think that, okay, the world's going to be okay. And that end is getting frustrated as well. Look at what's happening in our greater society today. And that's why I go back to the beginning. This is a complex issue. And if we treat healthcare like it's this thing over there, and then there's life over here, I would say that we're mixing it up in the wrong way. People want life, liberty, and the pursuit of happiness. And health is a big part of that. So how do we take on the bigger issues maybe not necessarily for all of us in the room, but hopefully so, but also for the next generations. And how do we start to break the curve? And I think even spending time like this here on this topic is sort of like a good way of saying we're moving in the right direction on a very complex issue that we have to come to terms with.
On that note, I'm afraid I'm going to have to wrap up the panel. Please join me in thanking our panelists, Steve Bird, Lynn Goldman, Q Ree, Bernard Tyson. Thank you for coming.
Thank you.